So,
Good morning, ma'am. Kavita.
Yeah. Hi, good morning, Deepak. How are you?
I'm good, ma'am.
Good.
yes,
This is the
ma'am.
fourth lecture in the series or the third?
Fourth.
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 Yes.
Twice a month?
Once
No,
in a
once a
Acha, okay. We started in September, is it? Or
yes.
August?
So, good morning, everybody. I'm Dr. Gayatri Egbote, and along with me, my colleague Dr. Deepak Malgutte has also joined. So, today is a special day because we have Dr. Kavita Krishna ma'am with us. Ma'am does not need any introduction because everybody knows her. Ma'am is a professor and head of Department of Clinical Immunology and Rheumatology in Bharati Vidyapit University Medical College and Hospital, Pune. She is not just a teacher to DM clinical immunology and rheumatology students, but she is also guide to various PhD students. And ma'am has over 130 publications. Ma'am is coordinator for virtual master classes, and she has taught many students, including me so far. Ma'am has given Colcon Oration 2020. Ma'am has received Colcon Oration Award 2024 in prestigious Indian Rheumatology Association conference at Bangalore. She's also received Best Paper Award at ZAPI and a Times COVID Warrior Award. She is a president of Women Health in Rheumatology Association, which is a very noble organization. She is a president-elect of Maharashtra Rheumatology Association, and she is also EC member of Indian Rheumatology Association. These are just few things about ma'am. There are many. But now today we are more interested in gaining knowledge about SLE. So she'll be talking about overview of SLE, and I hope everybody will be. I'm sure everybody will be benefited with her insightful lecture. You can go ahead, ma'am. Thank you.
Thank you for the kind introduction, Dr. Gayatri. Yeah, if you
Yes,
can
ma'am. I'll
stop
stop there.
sharing,
Yes, ma'am.
share. Yeah. One minute. Yeah, you can see the first slide. Am I
Yes, ma'am.
audible?
Yes.
And you can see the first slide, no?
Yeah.
Okay, I'll just move one more slide to just make sure it's.
Uh, now it didn't move. Now it's moved. Ma'am, you are unaudible. You are on mute.
Yeah, now I'm audible.
Yes.
Yeah. So just let me know if the screen stops moving, the slides. Yeah. Good morning, everyone. Welcome to another session of teaching by Maharashtra Rheumatology Association. The topic today is approach to systemic lupus erythematosus. And as you all know, it's a very multifaceted illness which can present anytime in any form. And often the patients affected are young women of childbearing age. And since they're varied presentations, often there is a delay in the diagnosis because many people do not know what's happening. And with the change in paradigm nowadays, the shift is more towards non-infectious diseases. So autoimmune diseases is one of them, and SLE is something about which you should always know. Because unless you know, unless you suspect, you cannot diagnose or treat. So we'll be discussing in some cases also in between, just to have an idea how these patients present. So let's see the first case. 28-year-old female presented with 4-day history of fever, body ache, blanching rash. And since it was blanching with a little leukopenia, little low platelets, dengue was positive. She was treated as dengue fever, which is common in our country, especially from the months of June to September. But after 1 month, when he called her back for a follow-up, there was fever, fatigue, arthralgia, though there was no joint swelling. The WBC count and the platelet count still remained lower. So at this point of time, we told her you should do, we did an ESR, which is 54, and we also advised her an ANA testing, but she said, no, I don't want to do it because it is expensive. And she took a discharge. But after 3 months, she presented like this with the rash all over the face and the forehead. And she was quite sick and she was still febrile. And the dengue was long back over. So, this is some new illness which we had to diagnose and treat. And this time, when we did the ANA test by immunofluorescence, it showed it was positive with a speckled pattern. The blot showed an anti-SM Smith antibody, which I'll be discussing these again. And she was diagnosed and managed as a case of SLE or lupus. So the learning objectives today will be, we will talk a little about history of lupus because that is interesting. Very little about pathogenesis and the defective apoptosis. This is important to know, but we cannot discuss in detail because it's beyond the scope of a single lecture. More important is the approach. So you have to understand what multi-system involvement is there, how to recognize these, how to investigate them, what is the must-do test, and which others you have to do, and which ones you should repeat, and a broad guideline for management, which are recommended all over the world. So that algorithm has to be followed. So lupus is known since around 850 AD, and the word lupus comes from the Latin word wolf, because the initial rash was, it looked as if they resembled the, wolf bites, like devouring lesions of the face. And if you look at the history from 1850 to 1900, the people were not sure, is it tuberculosis or is it something else? And that's why it is called the lupus tuberculosis era, where it was confused with skin tuberculosis. And they knew it's a cutaneous disorder mainly. And these lesions were compared to, if you can see the lower part of this, there's a pathogenic understanding. Around this time was that the lesions look as if they're devouring the flesh like a wolf bite, and the shape is like a butterfly across the bridge of the nose and the cheeks, and they thought it is like more like tuberculosis, but they sometime later found that it responds to quinine, which is an anti-malarial, and there was some response to steroid, which was discovered in 1950 by Hench, that came later. But till 1900, it was thought that it is just like tuberculosis. They tried some phototherapy, cauterization, X-ray, which none of them led to any improvement. After 1900, they realized that lupus could present without skin manifestation. There was systemic manifestation. So initially they called it disseminated lupus, and later on it was labeled as SLE, or systemic lupus erythematosus. So after the discovery of steroid by Hench, there were other slow discoveries. Better antimalarials were found, like mepacrine, hydroxychloroquine, chloroquine, etc. Then for many years, the treatment was mainly methotrexate, azathioprine, and tacrolimus, as though it was not available to us at that time. And then cyclosporin was also used. And later on, cyclophosphamide was discovered. Then rituximab, and then recently belimumab, anifrolumab. Then there are many other drugs which I'll discuss later. So suddenly there are many drugs, but it is challenging to test these drugs. The trials are very difficult because of the multifaceted presentation. So lupus vulgaris is a skin tuberculosis. It is scarring. It often is unilateral. It can involve any part of the face. Whereas SLE rash classically is a malar rash, a butterfly-shaped rash across both the cheeks and the bridge of the nose. And classically, it spares the nasolabial fold. And usually it is symmetrical, but it can affect the other parts of the body also. And over the years, skin tuberculosis has gone down in prevalence. So overall, it's an autoimmune connective tissue disease where there's an overplay of the innate and the adaptive immune system, which cause tissue damage. There are autoantibodies and immune complexes. Predominantly skin, musculoskeletal system, and kidneys are involved in most patients, but there can be hematological, serosal like pleuritis, pericarditis, lung, heart, etc., neurological involvement. And often they can come one after the other, one before the other. And it's like a spectrum. Sometimes you have only joint, and after a few months, they come with kidney involvement. So this keeps changing, but every manifestation is important when you diagnose. There is a very, very high female predominance. Males to female is just 1:9. And 90% of these females are again of the reproductive age group 20 to 30. So it's a very devastating illness for young girls who are in their early stage of career or marital life. So reproductive age group. So we have to diagnose it early to avoid mismanagement and to give them the best quality of life that ever is possible. And the treatment doesn't end at just 1 or 2 sittings. It goes on for years, 3 to 5 years, maybe more. We have to involve the family because the disease tends to flare and keep coming back even if you feel it's gone. So if you look at any standard book, you'll have a whole lot of clinical manifestations: skin, musculoskeletal, hematological, cardiopulmonary, vascular, neurological, renal, gastrointestinal, and ocular. Okay, so these are the whole list, but each patient can have different manifestation. You should know all, and you should know when to suspect. So most of the patients will present with either, majority of the patient present with skin, musculoskeletal, renal or hematological. Others are slightly rare, but when they happen, they are quite catastrophic. So out of these I've already told, they can have lung, joint, etc. involvement. The other manifestations like heart, either pericarditis, pericardial effusion, it can have eviction of the pancreas, there can be cognitive involvement, neuropsychiatric lupus as we call it, there can be vasculitis. In the end, I've written MAS, that is macrophage activation syndrome. A patient will present with fever and may have rashes, but the classical sign is a bicytopenia along with a low ESR. Rest of them will have high ESR, which is because of inflammation, high disease activity. But if a patient of lupus has low counts, fever, etc., with the low ESR, you must think of macrophage activation syndrome, which is again a serious complication of lupus. So you can see these pictures. Now I will discuss a few as the slides go. This is a classical advanced lupus arthritis. Advanced, so to say, initially, many of them will just have polyarthralgia, joint pain, swelling, but they do not have any deformities. But after some years, they can get these, but this is called Yakut's arthritis or Yakut's arthropathy. The J is silent here, Jaccouds. But these are by and large reducible. Though they look deformities, when you try to reduce or flex their fists, they can make a fist. So initially they are reducible, but later on they can become non-reducible. Hair loss can be like this, which is diffuse hair loss. This hair grows back with treatment. This is called diffuse or non-scarring alopecia. This is a scarring alopecia in this third picture C, which you see, where there are lesions called discoid lupus. There's scarring, and this part, unless treated early, doesn't grow the hair back, and this is called scarring alopecia or cicatricial alopecia. Similar in this picture D. This is a classic malar rash. You can see nasolabial fold is paired. It is in the sun-exposed areas. This is another type of rash on the sun-exposed areas of the hands, forearms, chest, and upper and the trunk, which is called subacute lupus erythematosus. So clinical manifestations, systemic are fatigue, malaise, fever, weight loss, which most of them have. Musculoskeletal is also there in most. Anemia, leukopenia, lymphopenia. Lymphopenia is classically seen in lupus, less than 1500, and low platelets. So these are seen in most of the patients. Besides this, cutaneous is there in 80%. Some of them may not have it in the beginning. They develop it later. It's a photosensitive rash in the sense when they go out in the sun, they may get it immediately or a day or two later, but the rash doesn't go away. It stays for a long time as compared to other photosensitive rashes, which are just solar hypersensitivity. They often have ulcers. They can have mucosal ulcers, which could be painful. They could be palatal ulcers, which are painless. Alopecia, we've already discussed. Discoid rash is a thick, scaly, disc-shaped rash, which can leave scarring. Neurological, they can have seizures, they can have strokes, they can have psychosis. Heart can be involved, myocarditis, they can have Lipman Sachs endocarditis. They are more prone to premature coronary artery disease. They can have effusions in the heart, that is pericardium, which is called pericardial effusion, which can be massive, sometimes needs tapping, and pleurisy, pleural effusions. Renal is an important manifestation. There are patients who just present with renal upfront. The skin manifestation may come later. So they present like looking like nephrotic syndrome, sometimes just heavy proteinuria, periorbital puffiness, pedal edema, or they can have cellular cast, hematuria, or active sediment, so we say, sometimes very late with end stage kidney disease when they are untreated. So 50% of the patients can directly present with lupus nephritis. GI manifestations are not so common. Very often they come later, like lupus enteritis or diarrhea, bowel wall ischemia, or pancreatitis. But we are getting patients upfront with GI manifestations also. Thrombosis can be arterial, venous. They can have coexisting antiphospholipid syndrome. A manifestation is not very common, but can be seen. So this is a classic. So when you talk about lupus, it is acute cutaneous lupus, subacute lupus, or chronic like discoid. So this is a classic acute cutaneous lupus, classically on the malar area, sparing of the bridge of the nose, but can be on the chin and other parts of the. This doesn't leave any scarring. This thick red skin, but when treated properly, it doesn't leave any scarring, but can leave some hyperpigmentation. So this is a subacute cutaneous lupus erythematosus, which is a often ring-like lesion seen in the forearm, chest, and back, again, which are more likely to be exposed to the sun. This is the chronic cutaneous or the DLE lupus. You can see a disc-shaped lesion with the thickening, scaling, and these often leave scarring. They can be anywhere on the face, sometimes in the ear, around the ear. And you can see they eventually leave scarring and some marks over there which don't go away. There's another case of old disc which is healed, but it still left scars here. Occasionally, you can have vasculitic rash in lupus. So usually it's a small vessel vasculite, so painful nodules on the palms or the legs. But if untreated, they can become larger. If they're very large ulcers, you could think of antiphospholipid antibody in these patients. Nail changes may be there. They can be a part of just discoloration because of disease activity, swelling around it, sometimes fungal infection, sometimes there will be vasculitic lesions or telangiectasia. So do look at their nails. Alopecia, as I said, this is a diffuse non-scarring alopecia, but this is a scarring alopecia which can lead to scarring, and the hair doesn't grow back in these areas. This is diffuse. With disease activity, there's a good chance with treatment the hair will come back in these patients. So these are symptoms that are devastating for the patient. As I said, they are young females, so these are cosmetic challenges also which you need to address. We should not just look at the biochemically abnormal reports. Another case of discoid lupus. So arthritis, as I said, we could get the classic deformities that I said, which are reducible, or initially they can just have swelling of the joint. So by and large, lupus arthritis is non-erosive as compared to rheumatoid arthritis, which non-treated can cause erosion. Deformities happen very, very late in lupus. So the joint part is usually less aggressive. There's a lot of pain and swelling, but deformities are reducible. As I said, this is similar to the previous picture. There is a Yakut's arthropathy, but these are usually reducible. They look like swan neck, but they reduce. Coming to hematological, anemia can be because of chronic inflammation, but they can have autoimmune hemolytic anemia where you'll have a direct Coombs test positive. Leukopenia usually is present, thrombocytopenia. Sometimes many of them are diagnosed as ITP, idiopathic thrombocytic, or they have no other manifestation. After many 2 years or 3 years, they come back with other manifestations. If they're APLA positive, then they can have increased risk of venous and arterial thrombosis, thromboembolic events. The thrombosis can be like a DVT, a pulmonary embolism, or a cerebral venous sinus thrombosis, like a stroke also they can present. Neuropsychiatric is very difficult sometimes to differentiate from infection, but all things are possible here. So it's a challenge to differentiate from meningitis and aseptic meningitis of a neuropsychiatric lupus. So you have to keep checking. There are certain antibodies which are more likely to be positive. They can present with central and peripheral nervous system manifestations. Nephritis is very important because if not treated in time, they can develop a chronic renal disease, and sometimes they present with overt proteinuria upfront, sometimes the rapidly progressive renal failure with a lot of active sediment. When you talk about active sediment in lupus, we're talking about RBCs and casts, etc. And then if you don't treat, there's a rapid decline in the kidney function along with hypertension, etc. So we have the 6 classes of lupus nephritis. Class 1 is a minimal mesangial lupus nephritis, which you just treat with general medications for lupus. But the moment it becomes class 2, 3, 4 is the most serious lupus nephritis, which needs to be treated more aggressively. They have sediment, they have proteinuria, and 5 is often got a better prognosis than 4. But many patients have uh, overlap. They may have 3 plus 5, 4 plus 5, etc. So we need to give immunosuppression according to the class. So kidney biopsy is important when we diagnose lupus nephritis or patients are not responding. When they reach class 6, advanced lupus sclerosis and lupus nephritis, they do not respond to immunosuppression. So when they just have proteinuria and they may go on dialysis. So in these patients, when they reach class 6, we have to give immunosuppression only if other systems are involved. The kidneys usually do not respond. So what are the indications for investigations in the lupus? First is to identify, is it really lupus? Then once we diagnose it, we have to monitor it, and also we have to monitor the side effects of the therapies. So we have a lot of criteria which have come in 1997. ACR stands for American College of Rheumatology. Later on, we had EULAR also, the European League of Rheumatism. So they have come out in 1997, 2012, and the latest is 2019. So in 1997, everybody did not have, testing for ANA. So we had these clinical plus 1 or 2 lab criteria, and we said 4 of any 4 more will do. And of course, there should be no other obvious diagnosis. So and these are classification criteria basically to enroll patients in trials. Sometimes there can be lesser criteria, but we can still have a high suspicion of lupus. Then in 2012, we got SLIC criteria. So these had to have 4 and more, but at least 1 clinical and 1 lab. Only clinical or only lab would not do. And then 2 others could be from either category. Where along with ANA, we got anti-DNA, we had anti-SM, we had anti-phospholipid antibody. A lot of labs came in besides the routine hemogram. The latest is the EULAR ACR combined, they have a consensus 2019 criteria, which is the latest. So these are important because these are weighted criteria. So for trial, these are important where you should have 10 or more to be classified, out of which ANA has to be positive. That is the entry criteria. All patients must have an ANA of at least 1:80 titer. That is the entry criteria. And then out of these, you must have 10 or more. And they got weights and highest in each category. Supposing a patient has acute cutaneous lupus, so it's 6. So even if they have, we count as 6 maximum of that category. Similarly, if you have low C3 and low C4, so that's 4. So you don't have to take this either of them. So this is how you do. But this again, I said, is more for drug trials. You can go by judgment and your experience, even if the criteria, and sometimes it becomes difficult to do the weightage in the OPD. So your experience matters. So first visit, now you think there's a lupus here, we're thinking of ANA that has come positive. What other labs you should do? It is not just the ANA. So every patient should have an ESR, CRP and inflammatory markers. So ESR is more important in lupus because that tells you more about disease activity. CRP can also be high, but if it's way beyond ESR, very high, you should always rule out infection. Infection and disease activity in lupus are always a challenge. Then, of course, you have to do a complete blood count, hemoglobin, the WBC count, the absolute lymphocyte, neutrophil count, platelet count. Kidneys have to be evaluated, urine routine for protein sediment. You have to keep checking the GFR, urine spot, protein creatinine ratio, and 24 hours protein you have to keep doing because sometimes spot sample may not give you enough information or it may come normal. But if you do the 24 hours, then we have to see whether nephrotic range or a subnephrotic range. ANA is the cornerstone. We'll talk more about ANA. Then there are many other antibodies which are positive. Some are specific and some have different positivity in different manifestations of lupus, and some can be positive other connective tissue diseases also because we have many overlap syndromes also. DSGN is an important antibody for lupus nephritis. Special tests whenever you think lupus is active or even for monitoring, you have to do C3, C4. These are complement levels. If they're low, then they tell you disease is active, and certain complications of lupus are more common with these. APLA, as I said, this is more important to rule out thrombotic risk of thrombosis in pregnant patients. Liver kidney, muscle has to keep on, you have to keep on evaluating these, because of the medicines that you're giving, side effects. And if the muscle is involved, it could be overlap myositis. Imaging, chest X-ray from time to time just to see for infection, fluid, ECG echo also because the heart can be involved. So you have to keep doing, not every time, but wherever it is required. And a baseline, you should do all these. Now, let's talk a little about the diagnosis. So, you should always know how it started, the lab testing. So, there was something called an LE cell, that's how the journey of diagnostic tests of SLE started. So, this hematologist, MM Hargrave, and which these scientists work in the Mayo Clinic. They were hematologists and they found this LE cell, which is a large macrophage, and it is engulfing certain nucleus of another cell. So tart cell is a different cell to what we have in lupus. This is the beginning. So this to shake, there was a bead-like bottle which is called the LE cell. You shake the cell and shake the bottle with the beads in that, and they should discover these cells. But after that, it's come a long way. And this is how the LE cell, which was discovered by Hargraves et al., in 1948, that was the beginning, it used to look. And before this ANA detection methods were discovered, this is the only thing we had for many, many years. Then what happened in 1942, a little before that actually, direct immunofluorescence had been discovered. But in 1954, the sandwich technique for indirect immunofluorescence discovered, which is very important for diagnosis of lupus. So the ANA testing has arrived from 1954 to date, and it's really evolved. So the indirect immunofluorescence assay is the classical technique now, which has improved and evolved as the basic detection for ANA. And white substrates are used, tissue sections, liver, kidney, etc. But it is a Hep2 cell. So they use cancer cells, they use this HeLa cell. So these are very cells with very large nuclei. Since all the antibodies are towards the nuclear components, so we needed cells with large nuclei. So they found Hep2 cells. Initially, they thought it was from the human laryngocarcinoma cell, squamous cell, malignant cell. Then they thought it's got contaminated HeLa cell, which was from a cancer cervix patient long back. And then now we also have 2000. So these are all large cells with large nuclei. And so we can get multiple antibodies detected because they have all the antigen. These cells are loaded with antigen. They're very large nuclei. And then you have these hepatocytes. So I'll show you how these look. So this is a typical ANA slide. If you're in a center where, where the ANA testing is done, do visit the lab once to see how it is done. So you have one cancer cell and one liver cell. Usually it's from a primate like a monkey. So this is a stable tissue and this is the cell. So you drop the patient's sample in both these wells that you call. And then what do you see after a particular process that is over? But before that, you should know when to advise an anti-nuclear test. Remember, the pre-test probability should be high. We should not just randomly advise ANA testing because it can be false positive. It is there in some normal people also. So it should not be used just randomly. You should have a high index of suspicion. That is one. And once the disease of lupus is diagnosed, you do not do serial ANA testing to say becoming negative. You can do, if it's negative, you can check later after 2-3 years if it's become positive. That is possible. But once it is diagnosed, there is no need to do again and again. It is not a part of assessment of progression or flare of lupus. It is not a periodic investigation. Now, there are certain diseases like you will read in your immunology, mixed connective tissue disease, autoimmune hepatitis, and drug-induced lupus, where ANA has to be positive. It's a part of the diagnostic criteria. But there are other diseases where it helps in diagnosis, like if you have a fever of unknown origin, you have other disorders like lupus, systemic sclerosis, Sjogren's disease, inflammatory myositis. This means that it may be a few percentage, it may be negative, okay, in spite of the disease. Any patient with an unexplained Raynaud's phenomenon, unexplained proteinuria, their ANA will help. So it is not 100% that it may be positive. Then there are some children with JIA, juvenile idiopathic arthritis. If they're ANA positive, they have a high risk of uveitis. And then also in Aplar syndrome, if you have a patient who comes first time with antiphospholipid syndrome, there if ANA is positive, then the prognosis becomes different. Okay, so it does not by itself add to the prognosis or diagnosis in diseases like psoriatic, rheumatoid arthritis, Hashimoto's, multiple myeloma, fibromyalgia. So do not advise in these cases, but above in these three, it's a must. In these three, definitely is very helpful. Other thing, what you should remember, as age increases, the ANA can be positive in normal individuals, especially in low titers. So even 1 in 320 can be positive in 3% of normal individuals. And the lower titers are positive in a very high percentage. So you have to do clinical correlation. So this is how these are the three different parts of ANA testing which are important. First, as I said, is the indirect immunofluorescence. It is the gold standard. When you say it's an entry criteria for all trials of lupus, it is an entry criteria. So this is done with a Hep2 cell test. Nowadays, we have Hep2000 also. Anti-DSGNA, there is no need to do immunofluorescence. You should preferably do by ELISA only, because that helps you specific, especially for lupus nephritis. And then after that, you need to know more whether what type of antibodies are there, because these patterns which are there may or may not give you enough information. So now we have line immunoblot, what is called LIA, or commonly called an ANA blot, and ENA. So this is a whole sort of different kind of antibodies you will see in one line. So all three are important. For entry, first you should always do an ANA by IF and then followed by an ANA blot. And dsDNA titers are basically more useful only in lupus nephritis. So this is how a typical ANA by IF report looks. You can see positive, pattern is speckled, grade 4 plus, and the dilution titer. So what does each of them mean? So this is just positive, negative. You have a negative control here. This is positive. So definitely this is very green immunofluorescence. This tells you it's positive as per the substrate. This is the intensity. So if it is just visible, it's 1 plus. So by experience, you will be able to tell how much positivity is there. Then come the dilution titers. So higher dilution. So it's not possible every time to do all the titers, because so most of the labs do around up to 100. Higher titers they do only if they're not sure, they want more information. But entry criteria is 1 in 80. So though we write, we can go higher and higher till it becomes negative. Practically, it's become difficult to do all the way up to 1 in 3,200. But that is what a dilution titer means. And then next is the patterns. So most common, most important is the homogeneous or diffuse pattern, which is a sign in lupus. And along with that, you have these, when you do the LIA, these are the antibodies which will come positive. I'll show you that also. So along with homogeneous, you often have DNA, antihistone, these antibodies on the LIA that will be positive. So this is quite classical of lupus, can be seen in rheumatoid arthritis also. Then you have speckled pattern, which is coarse and fine speckled, seen in lupus, along with that in Sjogren's syndrome disease. SS is Sjogren's syndrome, but now the new name is SJD, which is called Sjogren's disease. The terminology is changed. You can have in polymyositis, dermatomyositis, and progressive systemic sclerosis. Okay, and if you do a LIA, these are the antibodies which will be positive. Then your centromere pattern. You can see this is the in between. You can see this centromere. If you remember by your mitosis, meiosis from your school days or 12th standard. And this is classically seen in progressive systemic sclerosis, scleroderma. And you have nucleolar pattern, which can be seen in others. So these, some of them will have more than one pattern. Antibodies may be more than one, but you should be able to identify major patterns if you are looking at a slide. So if you see the patterns, this is the homogeneous, okay? This is speckled, and you can see this is the centromere. These are nucleoli which are, highlighted. So these come only with experience, but you should have some idea what do these patterns mean. So it is the way the immunofluorescence is seen, okay? So you can see this is nucleolar speckled, like they look like big, big dots, and homogeneous is uniformly stained. Other thing which you should know that ICAP, international consensus for these ANA patterns, is now come up with these numbers. You'll find some reports nowadays, AC1 to AC2, AC10, etc. So these are the numerical codes that are given. So you should be aware that they are supposed to be numbered also now. Unless you're trained, of course, you cannot number, but you should have some idea. The reporting is also evolving to a great extent. And this is by ICAP, okay? This is how a LIA or a line immunoblot, as if you can see the multiple antibodies here, and all these are becoming increasing day by day. So SM, if you see anti-Smith, SM is stands for Smith, the patient in whom this antibody was discovered. It is most specific for lupus. RNP is more specific for MCTD or mixed connective tissue disorders. SSA, SSB, the old names are anti-Ro, anti-La. They are specific for Sjogren's syndrome, and when they are seen in lupus, they are with SCLE. So in lupus, the good thing is that these patients are not that prone for lupus nephritis, which is more devastating. Then you have SCL70 for systemic. So all these antibodies are there. Out of this, I would just like to say about ribosomal P, that is more seen with neuropsychiatric lupus, so when you have CNS involvement. Drug-induced lupus is antihistone antibody. So the multiple antibodies, and these are going on evolving. So as you go on reading each connective tissue disease, you'll see which one is specific for what. But this is how it looks. You can see this, only the control is there. And here these different antibodies are. So whichever is positive will show this bar here, and that is how you diagnose it. Broadly, anti-dsDNA is specific, quite specific for lupus, more associated with lupus nephritis. Anti-Smith is specific for SLE, but no particular organ manifestation. Human RNP is more with MCTD. Ro and La or SSA, SSB is with Sjogren's, but with neonatal lupus and subacute cutaneous lupus, the pictures that we saw with ring-like lesions. And you have antihistone, which are seen in drug-induced lupus, and APLA, as we said, with antiphospholipid syndrome. Now, coming to treatment, we have mainly two categories: non-life-threatening, life-threatening lupus, renal and extra-renal lupus. Because whenever we have life-threatening lupus or renal, we have to be more aggressive with management to avoid morbidity and mortality. So treatment NSAIDs should be used only when really required for joint pains. Otherwise, you should avoid, because renal involvement can happen. So we don't want nephrotoxicity. Hydroxychloroquine is the cornerstone of treatment in lupus. And low-dose steroids are very important initially, but later on you should try to reduce the steroid dosages. And then systemic immunosuppressants are used as and when required. Skin treatment should be is very important. The dermatology treatment is, you can do it along with the dermatologist. Sunscreen or photoprotection is very important. Okay, and steroids local, which should be used, not used. Should not use very strong or potent steroids for the skin because it causes skin atrophy. Antimalarials and even tacrolimus can be topical or systemic. Topical tacrolimus doesn't cause that much skin atrophy, can be used. Then systemic medications used with consultation with the dermatologist. When you have life-threatening lupus, you have to use prednisolone in a high dose. Initially, you can use a pulse, but nowadays the trend is try to use only 250 milligram or so, avoid using very high dose. And after that, reduce the oral dose and try to make a maintenance of 5 to 10 milligram per day. If they do not respond, or as a steroid sparer, depending on the disease, you have IV cyclophosphamide, you have oral mycophenolate mofetil, and sometimes maintenance doses are also required. So these are the ACR guidelines. When you have non-renal lupus, you can be mild, moderate, and severe. HCQ is for all patients: sun protection, exercise, balanced diet, all vaccinations in time. Control of other things like blood pressure, lipids, glucose, etc. is important. Antiphospholipid antibody syndrome may require warfarin, aspirin, etc. Then the target is SLEDAI 0. We'll just talk about SLEDAI. HCQ should be there. Steroid, try to bring it down to below 5 milligrams or 5 milligrams per day. You may not achieve remission because sometimes the diseases just don't get cured, but at least we should try for low disease activity or which where the SLEDAI can be below 4. Again, there we try to bring minimum medications to these patients. Now, regarding if they do not respond, then what? The second line drugs we have, steroids we already talked about. If the joint pain and skin is more involved, you can give methotrexate. Azathioprine is also low dose, is okay for vasculitis, skin, etc. MMF or mycophenolate mofetil is good drug for nephritis. It is a must for most patients. But remember, if the patient is pregnant, childbearing, planning pregnancy, you have to not give certain drugs. Out of these, only hydroxychloroquine, azathioprine, and low-dose steroids are safe. Methotrexate, mycophenolate mofetil are not not to be given in pregnancy. Then if this moderate, you go on stepping up the treatment if it's moderate or severe. So the higher drugs are belimumab, etc., anifrolumab, which we don't have in India, but we do have tacrolimus, we have cyclosporin, that are called the CNIs. Those we can use. So many times we have to give 3 drugs. We give HCQS, we give a steroid along with some of these drugs. And if they're very severe, we talked about IV cyclophosphamide. And since we don't have belimumab, anifrolumab, we give rituximab, which we have, which is a B cell depletion drug. Renal lupus or lupus nephritis is very important. So here we have to, besides for proteinuria, we give angiotensin converting inhibitors, ARBs, SGLT2s are also coming in. If it's APS along with the heparin may be required. All the time you have to assess adherence to treatment. Many a time you think the medicine is not working, disease is progressing, but actually they are not taking the medicines also. The steroid, if very sick, you can give IV pulse, then bring it down to 3.3, 0.5. And if possible, less than 5 milligram of prednisolone to avoid side effects. Mycophenolate mofetil is an important drug unless the patients are pregnant. After that, if they don't respond, nowadays they say triple therapy. You give one more. So you can give tacrolimus, low-dose cyclophosphamide, azathioprine. So case-to-case basis and experience. If they don't respond, the rituximab we always have. So what are the targets? At 3 months, the urine protein creatinine ratio should go on decreasing. 25%, 50%. And ultimately, when you say it's remission, it should be less than 0.5 milligram or 500 milligram per day, 24 hours. And at the same time, the creatinine should not rise. The GFR should not be rising more than 10%. And this is how we have to monitor. So even if the patient goes in remission, we may have to treat the patient for at least 3 to 5 years. So they require a lot of counseling and compliance on part of the patient and regular follow-up. So do we monitor more? What do we monitor? So besides clinical and lab, we have these scores called SLEDI. The SLEDI 2K is followed where you have a clinical and a laboratory. It's a very extensive chart, but we should do it because ultimately we need a documentation. So we should try to do SLEDI on every visit or at least 3 monthly. But when we do, we see the manifestations or the reports of the last 30 days. And as I said, we aim for SLEDI 0, but we have to at least try for SLEDI less than 4. So this is how we do 3 monthly follow-up on these tests. If the patient is sick, call them every month. And these are the tests you do: hemogram, liver, protein, urine, etc. SLEDI 2K, you should chart at least every 3 months. And these tests are expensive: C3, C4, dsDNA. Eye checkup, you should do fundus for maculopathy because the patient is on hydroxychloroquine. And cataract, these patients get early cataracts. Annual eye checkup is important. And this is how a SLEDI chart looks. If you have to do it, you must do it every 3 months at least. ANA, as I said, do not repeat. ANA titers also did not correlate with disease activity. Once you diagnose, just leave it. You look at the other thing which I told you. dsDNA, but you can do. It correlates with disease activity, especially with nephritis, especially when you're trying to escalate therapy. There you can do by ELISA, the anti-dsDNA titers. C3, C4, again, once in 3 months you can do, or you feel there is a flare, especially in renal vasculitis or hematological manifestation. These are available now and useful tests. Certain situations, like if you're giving calcineurin inhibitors like tacrolimus, we need to do drug levels, we need to check blood pressure, you need to check potassium. HCQS sometimes can cause QTC prolongation. So you can check the ECG if it's an elderly patient or they're complaining of dizziness or syncopal attacks. Fundus baseline, young patients once in 5 years, but we recommend every year. And do not forget, certain other tests may be done, like if the patient is planning pregnancy, you can do anti-cardiolipin antibody, lupus anticoagulant, etc. All the same time, keep monitoring for comorbidities like diabetes, and you should see the vaccination status. Before you give all these B-cell depletion rituximab, you have to vaccinate them at least against pneumonia and influenza, which are patients need a lot of convincing because these are expensive vaccinations, not available free. And do not forget bone health. There are young patients who are given steroids for so long early, so they can get osteoporosis early. So you must send them, especially if they are above 40. Or you can do a FRAC score also. Early osteoporotic fractures are known in these patients. So remission, as I said, Low disease activity and remission are slightly different, but at least aim for a SLEDAI less than 4. If there is a low disease activity, adverse outcomes are less likely. So this is a 28-year-old female with fatigue, body ache, pain in all joints, malar rash. You can see on the cheek and the nose, high ESR, low TLC. This was positive. We diagnosed her as systemic lupus erythematosus, but she had no systemic manifestations. So we gave her hydroxychloroquine and low-dose steroid, which she responded. And then she went away, lost your follow-up, because that's what happened. They get better, they don't come. But after 2 years, she came with periorbital pedal edema, very heavy proteinuria, and there was a kidney biopsy which showed a high proteinuria. So this is a conference I attended recently. So now they call it a toolbox. You have all these drugs, there's so many drugs that you have in the armamentarium which you can give. So photoprotection, activity, mental health management should not be forgotten, because these patients do have, depression, etc. And initial treatments for lupus nephritis is class 3, class 4 have to be from these categories. And another thing which you should know about the future is cellular therapy, which I'll not delve into well into detail, but there's something called chimeric antigen receptor T cell therapy, which is CAR T cell, which is coming up in a big way. So you should at least know there are newer things which are happening with directly target. So in lupus, the target is the CD90. Okay, CD19. So these are specific. The patient's T cells are removed. They're attached to certain, receptors, and then they are made into, these are infused back into the patient's body, and these attack the target cell, that the CD19 directly. So these receptors are there which directly target the CD19. So the immunosuppression is not on the whole body, specific cells, just like how cancer therapy has evolved. So which is the best screening test for SLE? Anybody would like to answer? You can unmute yourselves. So the best screening test is ANA. Which type of arthritis is seen in lupus? Anybody's answering in the chat box?
Anybody wants to answer this
You
question?
can unmute and answer. Yeah.
Yes. So ma'am has asked, what is the type of arthritis seen in lupus? What type of arthritis is seen in lupus? So Isha is answered.
Yakut's,
Yes.
yeah, that's right. So non-erosive and Yakut's arthropathy, which later can be deformed, otherwise not, and it is non-deforming, non-erosive. Yeah, correct. Which is the most specific antibody for lupus? Did somebody answer?
Dr. Vanraj has answered dsDNA.
Yeah, so the most specific actually is anti-SM. But dsDNA is also important. Then which medication is the cornerstone of lupus management?
Dr. Tanvi has answered HCQ.
Yes, correct. The hydroxychloroquine is the cornerstone. What are the types of alopecia in lupus? Yeah, somebody's answered.
Dr. Bandrachis, non-scarring.
So one is non-scarring, which correlates to disease activity, diffuse hair loss, correct. And then the scarring one, which is, yes, correct. Cicatricial is scarring and non-scarring is diffuse. So cicatricial is associated with DLE, and so that leaves scars and the hair doesn't grow back. And the non-scarring, the disease activity decreases, the hair comes back. Yeah, very good. So you all are listening. Yeah, so the key takeaways are multi-system autoimmune diseases, diverse presentations, as you can see. AN is a good screening test, but should be used with wisdom. If not treated well in time, life-threatening complications can happen. So early diagnosis is important, as is the monitoring. Some slides, I don't know, they didn't come, so I'll just tell that there's something called, nowadays you'll hear type 1 and type 2 lupus. So type 1 lupus is what I just told you. But there are many patients where, you are giving everything, the ESR has come down, but they're not feeling better. They always complain of lack of sleep, brain fog, so that is called type 2 lupus. And they have all these symptoms which look like fibromyalgia. They do not respond to immunosuppression. So that is an area of research, but you should be aware there's something like type 2 lupus, which is not a part of these. There are different symptoms like brain fog, loss of cognition, etc., which need to be addressed more with counseling, etc. And the other thing was my pathogenesis slides also got messed up. So the main thing is that type 1 interferon. Just remember that it is a combination of innate and adaptive immunity, where type 1 interferon is the most important cytokine. Yeah. So SLE is diagnosed in clinical grounds in the presence of all these characteristic serological abnormalities. Commonly affects women of childbearing age with various organs and body systems. So a classical patient of lupus is a young girl or a female just married and can present common presentation just rash, leukopenia, pancytopenia, or nephritis. These are the three striking presentations where you should not miss lupus. A fever which doesn't respond and which people will go on doing cultures and think of tuberculosis could very well be lupus, okay? And if it has a variable cause, you cannot predict how much ever you try, you have all these antibodies, you cannot really predict which patient will have which manifestation, unpredictable in time and presentation. And often there's a loss to follow-up, lack of compliance also, which leads to these flares. And initial period should be high intensive therapy, immunosuppression, to control the disease activity fast. And you should come down on the steroid dose as long as you can. That you have to consolidate this treatment where you can prevent relapses, etc. Come down to a HCQ, lowest dose of steroid, and some immunosuppression as required. And if you don't control the disease well, the quality of life suffers. They have broken marriages. There are a lot of problems which Indian families have. Other comorbidities will set in, like osteoporosis, fractures, and that these medications can have toxicity. The regular follow-up and monitoring is important if you want to improve survival. So anybody, when is the World Lupus Day? Yeah, somebody's written. Yeah, so World Lupus Day is 10th of May, but the month of May is considered as lupus, where you have lupus awareness programs. So this is the last case where you should also know that all these autoimmune diseases are a spectrum. Today you think it's this, tomorrow it could be something else. The vigilance is very important. This was a 62-year-old female patient of mine, who was on weekly methotrexate, suddenly came with low WBC count. So the hematologist admitted as a methotrexate toxicity. Maybe she took extra dose, etc. Okay, so these are classic rheumatoid arthritis deformities. These are the feet. But look at her hair. She suddenly had so much hair loss. So it could be because of methotrexate toxicity. But when we severe hair loss so much suddenly due to a new drug, not common. So then we did a ANA and SM was positive. So there are entities like lupus which start as RA and evolve into a lupus. They have dual diseases. So what I'm trying to say here is autoimmune diseases are a spectrum. You have to keep a watch for other manifestations all the time. So thank you and have a good day. Gayatri, if there are any questions, we can take.
Yes.
Yeah.
At the age of 62 to diagnose SLE, is it
Yeah.
common?
Yes, ma'am.
Yeah. So
Ma'am,
adult. Yeah. So adult onset lupus is being seen nowadays. So the classical risk is during childbearing age, but all of us are seeing adult lupus also. So you should have an index of suspicion, what I'm trying to say here. And I have at least 5 or 6 adult lupus right now they don't respond also well. So eventually I had to give them rituximab. So though the majority, as we said, 90% are going to be between the age of say 20 to 30 or little here and there are 5 to 10% who continue to stay sick, or the ones who started at 20 to 30. Usually post menopause, they go into remission. But there are some who started late, and there are many of them who blame the pandemic, the COVID pandemic, that it happened to them after the vaccine, or we don't know what is happening to autoimmunity. But there are some. So this lady who was 62 years old, the husband kept arguing, she's taking methotrexate for 20 years. Why should she get a side effect to that now, And all the antibodies were positive. So subsequently she had proteinuria also. So you can go for a broader treatment in these patients like rituximab and all, which will address both.
Yes, ma'am.
Yeah,
Thank you. Ma'am, we have few questions in chat box. I'll take them
yeah,
one by one. If
yeah,
anybody
sure.
wants to ask any question, you all can put the questions in chat box. So, first question, second question is if ANA by ELISA is negative and patient had some CTD features like fever, arthralgia, then should we
Mhm.
repeat ANA by immunofluorescence or we just
Yes,
should do
yes.
ANA blot or
Yeah.
EM?
Phil, I think ideally you should do ANA by IF because ELISA is many times false negative, depends which lab has done it, etc. So IF is gold standard. But if there's a cost issue, you can do blood directly. That's fine. And you have to correlate with the clinical features also.
Yes, ma'am. Ma'am, for how long should HCQ be continued in an SLE patient?
Yeah.
If suppose somebody has major organ manifestation.
So as long as you can. So no, when do you not? So the main thing, as I said, is the maculopathy. Once the ophthalmologists say the macula is now not good, so then we should ideally stop because the vision may go down. That is one. So we try to give as long as we can. Then there are very occasional patients who just don't tolerate it. Like, and they say I just get some uneasiness, dizziness. So there are very few of those, of course. The most common thing that I've seen in the last 2, 3 years is the skin pigmentation. So
Yes.
most of the lupus patients initially, I mean, they have lupus rash also, but even if the rash subside, they start getting a slate gray pigmentation. Like initially, the thing is just a tan, but it is quite, especially the patients who are very fair. So some of them just don't want to take it. They require a lot of counseling there. But there are one or two of mine who have refused to take it because, of course, they were better. They went into remission. So then they are on mycophenolate mofetil. But yes, you have to give it as long as you can until they develop a maculopathy or a prolonged QT syndrome, or as we said, they develop some side effects which they are not willing to take, like the hyperpigmentation.
And ma'am, how do you do the monitoring, regular monitoring for the
Yeah,
patient?
for eye. So I usually do a baseline, but in young patients, I don't wait for that report. I tell them, "Ki start and come back next time and do." Then if it's a young patient, I can tell them to do after 5 years, then annual. But by and large, I do it every year. And then when you tell them every year, also they don't do it. They do it after 2 years. They do it when they feel like. But recently, I had a patient. She is just 25 years old who delivered. After that, she had very severe, extensive pedal edema. And they thought initially it's just pregnancy related and she had a hypertension, preeclampsia, etc. But it was not going. And then she came to me that it was no skin manifestations or everything positive for lupus nephritis. And she did not, she I started on HCQS also, but I just told her go to the ophthal and come. So he called me. He said ki the macula is very bad. She has severe maculopathy already. So I don't know the cause, whether it's an autoimmune disease or what. So I did not give her. Yeah. So that is only one patient where the baseline fundus was not normal. Then there is elderly lupus that I told you. I have around at least 8 to 10 who are above 50, 60. They're often by then they are diabetics also, and also their macula also bad. So then they also have not given. The baseline I usually do. It's better to do it. Yeah.
Okay. Yes, ma'am. Ma'am, do you consider steroids in all lupus patients?
See, unless they're very, very mild lupus, most of them initially need. If they're very occasional patients whose mother or sister has got lupus and they come, then ANA positive and they have nothing. So those obviously we don't. The SMILE trial for what is that called? Incomplete lupus is there where only antibodies are positive. So HCQS earlier has not prevented. So very mild, just positivity, then they don't need steroid. What they say, even for mild leukopenia, you don't need to give steroids. But by
Yes,
the ones who come here quite extensive rash and have polyarthralgia, the initial small dose, yeah, depending on the severity.
true, ma'am. Uh, Ma'am, next question is SLE with AIHA in crisis. Despite immunosuppressant therapy, how do we treat? Somebody
Immunosuppression, yeah. Yeah, so
already has
they
got AIHA. Yes, ma'am.
diagnosed case of lupus, no?
Yes, lupus with AIHA already has got immunosuppressants. Now she is in AIHA crisis. How do we treat?
Yeah, so you have to give steroids also, and then discuss with the hematologist, what would be the best option. There are many options you have, because these patients, the more blood you give, they just gets hemolyzed,
Yes,
So
ma'am.
you have rituximab, you have IVIG, whatever works, yeah.
Yes, ma'am.
Yeah.
Ma'am, you have already discussed about that in your slides, that if we can go for pearl steroids, and we have to do APLA also in such cases. We have to rule out CAPS, and probably we can go for plasmapheresis, plasma exchange, or IVIG. And
Yeah,
then
IVIG.
or else rituximab. Yes, ma'am. So
Yeah.
the last question is,
The
can
plates,
fibromyalgia?
APLA, APLA is more important when you have a low platelet count, So
Yes, ma'am.
AIHA sometimes may just have a low hemoglobin. Yeah.
True. Yes, ma'am.
Yeah.
Uh, Ma'am, last question is, can fibromyalgia suspect patient needs to go for lupus workup?
No, no, you should not do just for all. You should see what, at least first, you can just do the inflammatory markers, So fibromyalgia needs a good history. You have to ask, do they sleep well? And though now the fibromyalgia point examination is no longer, it's no longer recommended by the guidelines, but you can still see are there too many tender points, especially around the trapezius, that's one point which you can check, that quick examination. So I wouldn't recommend ANA upfront for which you suspect. It adds to the confusion if they have a titer of 1 in 40. And nowadays you have reports of anti-DFS 70, so that itself, that alone is positive, rest all is negative. So that adds to the confusion. So I wouldn't recommend for all, but if they have history is more important. If they have morning stiffness, polyarthralgia severe, if ESR is high, definitely you should.
Yes, ma'am. Thank you so much, ma'am, for giving us the wonderful and excellent session on Sunday morning, Sunday morning especially. And your approach was very clear. It was very practical, and you did give us some real life scenario. And you had wonderful pictures, lab scenarios, etc. And we look forward to have many more sessions with you.
Yeah.
Thank you, audience, as well. Thank you, Deepak. Thank you, Vikram sir. And thank you,
Thank
MRA.
you.
Yes,
Yeah,
ma'am.
thank
Thank you
you.
so much.
Thank you.